Hey everybody, Dr. Avizo here. In this video, we're going to talk a little bit about heart failure. Now, one thing that I definitely want to make sure that we say before we go any further is that there is an entire video on the RAS system, okay, and I would recommend going back, watching that RAS video first, because a lot of what we talk about here is going to be built upon those principles, and that's a pretty big video. So I'm not going to go too much into detail on the pathophysiology in this video because we covered it in such great detail in that video. So I would go back, watch that. Once you have a good grasp of the RAS system, I would recommend coming back here, and then, we'll start off kind of where we left off with heart failure. We'll talk about some different types of heart failure, and then in the next video, we'll go into how these all kind of relate to cardiomyopathies. Okay, so we're going to tie that into the next video. So this video is kind of in the middle of the two. I'm going to go back to these pharmacologic targets again. We already covered some of this in the RAS system video. We're going to build on it a little bit here. So the way that I kind of want you to think about this, and again, I know I talked about this a little bit in the RAS system video, but I want you to kind of think when we're talking about heart failure, the bad guys are going to be, renin, aldosterone, angiotensin 2, right? These guys are all going to be kind of precipitating this cyclical cascade that we'll see in heart failure that tends to exacerbate the remodeling effects on the heart. Now, somebody else to remember here in terms of the bad guys, so to speak, is going to be norepinephrine. Okay, so norepinephrine and in general, catecholamines are also going to kind of fall into this category. And when we're talking about the good guys in heart failure, those are going to be the mediators that have the opposite effect. So your atrial natriuretic peptide, your brain natriuretic peptide. Remember, these are going to be released by the atria and ventricles in response to increased stretch. So when there's a lot of volume, you're going to get ANP and BNP being released, which is what happens in heart failure. So let's just talk about this really quickly. And again, we go through this a lot in the RAS system video, but let's just go through this really quickly. How does this all happen? So let's just take systolic heart failure to start with because it's a little bit easier to talk about. So let's say that we have a patient that has difficulty ejecting blood from the left ventricle. Okay, so typically, what we'll look at is we can say, well, we can look at the cardiac output or the ejection fraction, right? The ejection fraction being the amount of blood that's being ejected with every contraction. Okay, so we can look at the ejection fraction. We'll just call it the EF here. Okay, so if the EF is low, I'm not ejecting a lot of blood from the ventricle with each beat. So what's that going to do? Well, if I'm not ejecting a lot of blood, that blood is going to get backed up, right? So it's going to get backed up. And when you're thinking about this, I want you to think about this kind of systematically. So you have the left ventricle, you have the left atrium, and then we'll just put, the lungs over here. And then we have our right ventricle, and we have our right atrium. And then down here, proximal to this, we're going to have our jugular veins. Okay, so we'll have our jugular veins. We'll have the liver. Okay, remember, all of these venous systems are kind of tied together, right? The liver is going to eventually drain into the inferior vena cava, which goes to the right atrium. And then the jugular veins will drain into the superior vena cava, which also goes to the right atrium. And then I'll just put our peripheral veins here. My point here is as this blood gets backed up, right? So if my left ventricle, if my ejection fraction is really low, then my left ventricle is really not going to be ejecting very much blood. There's going to be a lot of blood remaining in this left ventricle. And that blood, because it's not really moving, right? As more blood comes in to get ejected by the left ventricle, that blood is going to have nowhere to go. So it's eventually going to get backed up here into the left atrium. And that can cause left atrial dilation. You're at higher risk for atrial fibrillation, right? Some of the other things we talked about. That blood will then back up into the pulmonary veins, right? It'll back up into the lungs. And once it backs up into the lungs, that's where we get pulmonary edema, right? When this backs up into the lungs, we have so much blood sitting in those pulmonary capillaries that the hydrostatic pressure gets really, really high, and it forces that, some of that fluid into the lung parenchyma. And that's where we see pulmonary edema, which we'll see in a second. So, big point to remember early on here is if you have left ventricular failure, okay, if you have some kind of left ventricular heart failure, that can cause pulmonary edema because just like we said here, it can back up into the lungs. Now, what about on the right side of the heart? What if there were some issues with the right ventricle? So if the right ventricle wasn't pumping enough blood, for example, right? If it wasn't pumping enough blood out into the pulmonary artery, into the lungs, if it wasn't able to do that really efficiently, then the same thing is going to happen. The right ventricle is going to be accommodating more blood. That blood is eventually going to get backed up because we're not ejecting enough of it. So it's going to get backed up into the right atrium. But then what happens? Well, that blood, if it continues to back up, it can back up into the jugular vein. What will that cause? That will cause jugular venous distension. Okay, it can back up into the liver. If that blood backs up into the liver, we can get hepatomegaly, sometimes called a nutmeg liver. And that's due to ischemia, because you have so much fluid sitting there in the liver that you're not able to get very good perfusion because all that fluid is kind of backing everything up. Okay, and then you also get some fatty degeneration because of that. But anyway, so hepatomegaly, that's why you have hepatomegaly. And you can also get ascites, right? This is all from this backup of fluid into the peripheral nervous system, right? You get peripheral edema. And usually it's going to be more gravity dependent. So in the lower extremities, typically these patients will have peripheral edema. You put your thumb kind of over the pretibial surface, put some pressure there for a full 5 to 10 seconds, take your thumb off, and you can see that there's still some pitting there. And I'll show you a picture of that in a minute. So the point here is that this right-sided heart failure can cause jugular venous distension. It can cause hepatomegaly. It can cause peripheral edema. And we know that the left-sided heart failure can cause pulmonary edema. But right-sided heart failure in and of itself should not cause pulmonary edema. That's particularly high yield because, look, the right ventricle is proximal to the lungs. So if this blood backs up, it's not backing up in the lungs. It's backing up proximal to that, right? Proximal on the venous side. This is where it gets tricky. What's the most common cause of right heart failure? The most common cause of right heart failure is left heart failure. Okay, so when the left side of the heart goes, it's going to back up. Where do you think? After it backs up in the lungs, it's going to go to the right side of the heart, and then it can eventually reach all of these other areas. Okay, so the point is, if you have exclusive right-sided heart failure, you shouldn't have pulmonary edema. If you have left-sided heart failure, maybe you have a low ejection fraction, like we were just talking about, that kind of started this whole process. If a patient has left heart failure with a low ejection fraction and they have hepatomegaly and peripheral edema, then you know they probably have right heart failure too, right? So these are where you put this whole system together to kind of figure out what's going on clinically. So if they show you a picture of an x-ray with pulmonary edema in the setting of this low ejection fraction, they most likely have left-sided heart failure and or possibly right-sided heart failure. They'd have to give you a little bit more information for you to, concretely make that decision. Now, this is systolic heart failure. That's where we have a low ejection fraction and we have a backup of blood that's causing these symptoms. Now, think about this, right? You have systolic heart failure, okay? You're not ejecting enough blood. Your ejection fraction is very low. Okay, so if your ejection fraction is very low, that means that the blood that's going to the tissues, sometimes we call this the effective circulating volume, the ECV. So the effective circulating volume is the actual amount of blood. If I looked at a cross section of my blood vessel, effective circulating volume is the blood that's in that blood vessel carrying oxygen or carbon dioxide to the tissues. So we're not counting all of the fluid that's sitting in the interstitial space when we look at the effective circulating volume. We're just looking at the blood that's going to tissues to provide perfusion, okay, of oxygen or carbon dioxide. So what happens is if my ejection fraction is low, my effective circulating volume is going to drop, right? I'm not going to be getting a lot of blood to my tissues because I'm not pumping out a lot of blood. So then what happens? Well, because of that, when I look at my kidneys, right, remember in the RAS video, if I have less blood getting to my glomerulus, that's going to decrease my GFR. That's going to cause renin to be released, okay? And then that will eventually cause angiotensin 1 to get converted to angiotensin 2 by ACE, and then aldosterone release. So we're just going to write RAS here because we talked about this whole thing in the last video. But the point is, when there's low effective circulating volume and a decreased GFR at the level of the glomerulus, that's going to cause an increased stimulation of RAS, right? So that's the aldosterone, the angiotensin 2, the renin, and what all of these are going to do. So we're going to get vasoconstriction, mostly from the angiotensin 2. That's going to increase the afterload, okay? And aldosterone is also going to increase sodium reabsorption. Okay, so we're going to get more sodium reabsorption at the level of the kidney. What is that going to do? That's going to cause more fluid to be retained. And guess what? We already have a fluid problem. We have all of this fluid backing up because my ejection fraction is low. Now I'm reabsorbing more sodium because my body thinks that I don't have enough blood volume. The reality is we have too much blood volume. It's just not effective in circulating to the tissues. It's all backed up. And so now we're in a vicious cycle where we're holding more and more water because we're reabsorbing sodium. So you can see that this actually becomes, like I said, a very vicious cycle where we're retaining more and more fluid. As we retain more and more fluid, the ANP and the BNP are going to start to go up, right? Because these are markers of ventricular and atrial stretch, right? So as these are all going up, they're going to cause the ANP and the BNP levels to get elevated. This is why a lot of times in heart failure, we look at a BNP level on the patient to see how fluid overloaded they are. It has some prognostic significance, right? A very high BNP level might tend itself to be consistent with a patient that has heart failure for these reasons we just mentioned, right? And so the BNP and the ANP are trying to counteract the RAS system, right? They're going to have the opposite effect. Remember what they do. ANP and BNP are going to have the opposite effect of the renin-angiotensin-aldosterone system. So if the RAS system causes vasoconstriction and sodium reabsorption, then ANP and BNP must cause vasodilation, right? Vasodilation. And instead of retaining fluid with sodium reabsorption, we are going to have increased diuresis by getting sodium to be excreted in the urine. That's natriuresis, right? So in other words, we have decreased sodium reabsorption, we have increased sodium excretion. We're removing the sodium through the urine. That's what the natriuretic stands for in BNP and ANP, right? So that's where the natriuresis comes in. And remember, the key that we talked about in the last video on the RAS system is that water follows salt. So if I'm voiding sodium, right? If I'm voiding salt, then water is going to get voided. So this natriuresis is going to lead to a diuresis, right? And that's going to get this fluid that's all backed up, it's going to get it to be voided out. So that's why the BNP is going to be elevated. It's going to be elevated to try to counteract this RAS system. Now, over time, the RAS system is eventually going to win. Okay, so over time, the RAS system is going to win. The BNP can only kind of balance things for so long. And the other thing I want you to remember, because step one's all about mechanisms, remember that this pathway, the ANP-BNP pathway, primarily going to work through CGMP. Remember, CGMP, we think about that a lot with nitroglycerin, right? Because it has the vasodilation components. That's kind of how I remember that. So I think that's a pretty good summary. So that's what's happening in systolic heart failure. And just to recap it and really quickly here, low ejection fraction, low effective circulating volume, everything gets backed up, and it just continues to be in this vicious cycle as the RAS system keeps getting activated because we don't have enough renal perfusion going to those tissues. And the other thing is the baroreceptors are also sensing this lower level of perfusion of effective circulating volume because all of the blood is backed up and very little of it is actually getting ejected from the heart. And so that's where the catecholamines come in. This is all getting released because we have sympathetic stimulation from the RAS system, but also because our baroreceptors are recognizing that the pressure is going to tend to be on the lower side because we have a lower effective circulating volume in some cases. So anyway, so that's where this all comes from. And then the BNP, like we said, BNP and ANP are trying to counteract this RAS system, but eventually they lose, right? And that's where we start to get this remodeling of the heart that causes heart failure and makes this worse and worse. And we'll talk more about that in cardiomyopathy. So just to simplify things, principal determinant here is low contractility leading to high volume. Now, in diastolic dysfunction, things are a little bit different, but it's really the same pathway and the same concept. In diastolic heart failure, the issue is not contractility. Usually the ejection fraction is actually okay. The issue in diastolic heart failure is that there's an impaired ability of the ventricular walls to relax. So we can think of this as impaired relaxation in diastolic heart failure. And that impaired relaxation, it doesn't allow us to accommodate very much blood. The ventricle is very non-compliant. It's kind of stiff is one way to remember that. So sometimes you'll see this reference when we're talking about the S4 heart sound, okay, which is very classic for diastolic heart failure, and we'll talk about that in a second. But a very stiff ventricle is what we're talking about in diastolic heart failure. So this tends to happen over time if there's very high pressures. If there's very high pressures in the ventricle over a long period of time, the ventricle is going to get very stiff in accommodating that. And that stiff ventricle is eventually going to lead to a decrease in the ventricle's ability to be compliant. It can't accommodate blood. It can't accommodate higher preloads. And so the same thing is going to happen. If my left ventricle can't accommodate this amount of blood that's coming into it, right, then that blood is going to get backed up. And it's really the same concept. And then that blood gets backed up and so on and so forth. And then we end up in heart failure. So the difference is it's not how much blood is getting ejected. It's the heart's ability to accommodate that blood. That's the problem. And that's usually due to usually long-standing chronic hypertension. High pressures can do this. It can cause there to be this diastolic component where we have impaired relaxation leading to poor compliance, backup of blood. And sometimes you'll see this systolic heart failure written as heart failure with reduced ejection fraction, right? That should make sense. That's the principal problem. And then diastolic heart failure with preserved ejection fraction. The ejection fraction isn't the issue, it's the compliance of the heart. That's the primary problem. There's also high output and low output heart failure. This has to do with the cardiac output. Low output cardiac failure is similar to systolic heart failure, but the thing is it's more of like a cardiogenic shock picture. It's when things get kind of to the extreme. I'll show you that that in a minute. Not quite as high yield though as these top two. One other thing I want to kind of touch on here that I didn't talk about yet is if you had left heart failure, you can have a functional mitral valve regurgitation. So what does that mean? So again, if you're not ejecting enough blood out of the heart, you're not able to accommodate this blood, that blood can go back to the left atrium. But remember, what's between these two structures? That's the mitral valve. So if there's so much blood in the left ventricle that it can't be accommodated any longer, it's going to push through that valve and it's going to cause classic mitral regurgitation, heart murmur. But the point is that I want to make here is that this is a functional mitral valve regurgitation. In other words, if you treat this patient's heart failure, the mitral regurgitation should go away. If this patient had a primary mitral valve regurgitation, then that would be an actual problem with the valve itself usually. Okay, so sometimes this is also called a secondary mitral valve regurgitation because it's secondary to the heart failure. And that same is true on the right side of the heart, right? You can have this happen with the tricuspid valve as well. The other thing is under settings of hypoxia, right? If this blood is just sitting in the lungs, but it's not really moving very well because a poor ejection fraction or diastolic heart failure, then you can get hypoxia to the lungs. And when these vessels become hypoxic, remember the pulmonary vessels, this is particularly high yield, when they have hypoxia, they vasoconstrict. Okay, and that can lead to pulmonary hypertension, and that can lead to worsening of right heart failure because now the right ventricle has to pump against a higher pressure to get through to the lungs. Okay, so this is why this is all a vicious cycle. Last thing here, pleural effusions. If you tap a pleural effusion in heart failure, it's going to be transudative. Okay, so remember that. These are transudative. Go back to your Lights criteria. Okay, and that's because the hydrostatic pressure is pushing fluid out into the pulmonary parenchyma. This doesn't have to do with malignancy or infection or anything like that. Okay, so that's why this is transudative. All right, so kind of what we just talked about in the last slide, but I just wanted to touch on these again. Subjective, typically these patients will present with shortness of breath. In the more severe stages, it'll be at rest, okay? So sometimes they'll present it that way. We'll go through a whole classification for this for step 2, but for step 1, this is really what you have to know. Orthopnea has to do with shortness of breath when the patient is lying flat. Sometimes these patients they'll say in the board question, they'll use 2 or 3 pillows when they're sleeping. They're almost always talking about heart failure when they mention how many pillows the patient is using, right? PND or paroxysmal nocturnal dyspnea, again, this is kind of the same concept. The patient is, laying down for a long period of time and they're getting short of breath at night. So that's kind of what the PND is. And we don't need to go into great detail on that. These are just some of the classic findings. So shortness of breath all has to do with this pulmonary edema. Now remember, if I have a patient that has right-sided heart failure and it was only right-sided heart failure, let's say, what would cause you to just have right-sided heart failure? Maybe you have idiopathic pulmonary hypertension or interstitial disease in the lung. The left ventricle doesn't get affected by that, right? Those high pressures from pulmonary hypertension are going to back up into the right ventricle, okay? And that's going to cause right-sided heart failure exclusively. Those patients should not have pulmonary edema from heart failure because the right ventricle is proximal to that structure, right? If we're looking at the flow of blood, right? So those are the things to really kind of keep your eye on when you're looking at these questions. They really like you to distinguish where the principal problem is. Okay, again, these are things we already talked about. Jugular venous distension, pulmonary crackles from the pulmonary edema. If they have reduced lung sounds, that can be because they have a pleural effusion. Okay, remember, you can also have a pleural effusion. How do you look for pleural effusion? Costophrenic angle. So here, if I just look at this angle, it's really sharp in this x-ray, right? So this one actually looks okay. I don't really see any fluid in the lungs here. I'm looking for these opacities, kind of hazy opacities. Here you can see bilateral airspace opacities, right? So you can see here a lot of congestion out of these pulmonary vessels. Okay, and then look, I don't really see these sharp costophrenic angles here. I kind of just see a blunting. It looks almost like some fluid sitting over here, right? So this is going to be a pleural effusion. So this patient might have reduced lung sounds at the bases, and they might have crackles in the mid and upper lobes, potentially, right? That's the way a board question would probably ask about the findings in this patient, right? So reduced lung sounds because of the pleural effusions. Again, if I tap this pleural effusion, that's going to be transudative, right? And again, seeing something like this would tell me this patient probably, if this is a heart failure question, this patient probably has left-sided heart failure, right? Just based on this finding alone. And these arrows here are pointing to these kind of straight lines you can see kind of going horizontal against the pleural fissure here. These all have to do with these curly B lines, which these are essentially going to be these very kind of short lines that are perpendicular to the pleural surface, like we said right here. These are very classic for these curly B lines. Very subtle finding, but just something to kind of go along with, if you're thinking heart failure, those are things I'll sometimes show you to kind of push you in that direction. But this is going to be your classic x-ray for a heart failure patient. This is a normal x-ray. So I put it side by side just so you can compare the two. And then here you can see this classic pitting edema. Usually you want to do this over the tibia, right? So here's your tibia. You're going to push over the bone. So you're looking at the pretibial swelling, and you can see that there's this indentation here after the examiner removes their finger. That's very classic for pitting edema. And we'll talk more about how to grade that and that kind of thing for step 2. So just some other findings here, and I don't want to go into too much detail, but a shifted point of maximal impulse. So usually kind of at the apex, it tends to be laterally displaced. So they'll say it's beyond the midclavicular line. That's very classic in heart failure. A left parasternal lift if we have right-sided heart failure, right? So the shifted PMI is mostly left-sided heart failure because, again, we're talking about apex left ventricle. In right ventricular heart failure, the classic way to describe that is, again, left parasternal lift. S3 heart sound, you can see whenever you have some kind of backup of fluid, usually the S3 heart sound is going to be reflected of rapid filling, right? So if I have my left atrium here and left ventricle here, and let's say that I have a backup of blood. I have a whole bunch of blood sitting in this left atrium because of my heart failure. As soon as that mitral valve opens, that blood's going to rush out because I have so much of it sitting in the left atrium. And that's what generates that S3 heart sound. It's this rapid ventricular filling because of fluid overload. Okay, so the S3 heart sound is mostly having to do with fluid overload. The S4 heart sound, on the other hand, has to do more with a stiff ventricle. So this is very classic for diastolic heart failure specifically, whereas S3 can be seen in either one, right? Because in either case, you can have fluid overload. But again, remember what the S4 heart sound is. Again, so if this is my left atrium, this is my left ventricle. Remember, at the very end of diastole, right, when we're filling the left ventricle, okay, so first we have the rapid filling phase, right, there's a bunch of blood that goes in, and then towards the end, there's still a little bit of blood left here in the left atrium, and so the left atrium is going to contract. There's going to be atrial systole. This is your atrial kick, right, and it's there just to kind of get some more blood out of the left atrium. So what happens is if this ventricle is very stiff and it's not accommodating blood very well, when I try and kick into this left ventricle, there's already going to be a very high pressure here, okay, because there's impaired filling, there's impaired diastolic function. That increased pressure is generating the S4 heart sound when I try and kick this blood in. So that atrial systole at the end of diastole is causing that S4 heart sound in diastolic heart failure classically. So if you see S4 heart sound, they might be telling you something more along the lines of diastolic heart failure. So just keep that in mind. And the other thing on here is that the BNP, like we said, tends to be very elevated because it's trying to compensate for this massive fluid overload that's happening in this vicious RAS activation, sympathetic activation cycle that's going on.